Let's jump right into sorting neck and mediastinal masses for Step 2 CK, focusing strictly on high-yield clinical decision logic.
First up, pediatric neck mass sorting.
When you're looking at a pediatric neck mass on the exam, remember that location and physical movement directly drive the diagnosis. We start by dividing these masses spatially. If it's midline, you're usually looking at a thyroglossal duct cyst or a dermoid cyst. If it's lateral, think branchial cleft cyst or reactive adenopathy. This table maps out how specific embryonic remnants tie to exact cervical regions. For instance, thyroglossal duct cysts form right along the path of thyroid descent, tracing from the foramen cecum at the base of the tongue down to the anterior neck. Laterally, branchial cleft cysts can have tracts that extend inward toward the tonsillar fossa or the pyriform recess.
Let's lock in the high-yield pivot points here. If a midline mass moves vertically when the patient swallows or sticks their tongue out, that guarantees a thyroglossal duct cyst. Dermoid cysts are also midline, but they won't budge with tongue protrusion. For lateral masses, if it's positioned right anterior to the sternocleidomastoid, it's a branchial cleft cyst. Now, if you see a lateral necrotic node paired with violaceous skin and maybe a fistula, that points directly to an atypical Mycobacterium avium infection. And don't forget cystic hygromas. These feature dilated lymphatic vessels and reliably show up in the posterior neck.
When managing a thyroglossal duct cyst, you must confirm normal functioning thyroid tissue before moving to surgery. Your diagnostic test of choice is an ultrasound to verify a normally located thyroid gland in the neck. You have to make sure that ectopic tissue isn't the patient's only functioning thyroid. Once that's confirmed, you proceed with the cyst trunk procedure, which is the surgical resection of the cyst, the associated tract, and the central hyoid bone.
Moving on to adult neck mass red flags and squamous cell carcinoma.
Transitioning to adult patients, our threshold for suspecting malignancy drops significantly. A persistent, firm neck mass, a mucosal ulcer, weight loss, dysphagia, or a history of tobacco and alcohol exposure should immediately raise red flags. If you see an enlarged, ulcerated tonsil along with ipsilateral cervical adenopathy, think oropharyngeal squamous cell carcinoma. If the patient is younger and lacks those traditional smoking or alcohol risks, an HPV etiology is highly likely. And a laryngeal ulcer in a smoker, that's a classic presentation for laryngeal SCC. Here is a rigid diagnostic rule for Step 2. Persistent hoarseness requires an immediate laryngoscopy to rule out vocal cord cancer. While you're at it, keep laryngeal papillomatosis in your differential. Vertical transmission of HPV 6 or 11 can cause recurrent respiratory papillomatosis, presenting as finger-shaped growths on the true vocal cords that cause that hoarseness. The treatment for those is surgical debridement. Take a look at this diagram mapping out referred otalgia. Sometimes cervical lymph node enlargement or ear pain are the only presenting clues for a hidden cancer. A tumor at the base of the tongue can actually refer pain straight to the external auditory canal via the glossopharyngeal nerve, cranial nerve 9. Meanwhile, a posterior pharyngeal wall tumor refers pain via the vagus nerve, cranial nerve 10. So what happens if a biopsy of an adult neck mass comes back positive for metastatic squamous cell carcinoma? What is the mandatory next best step? You order a panendoscopy. This includes an esophagoscopy, a bronchoscopy, and a laryngoscopy. It is the best initial test to locate the hidden primary tumor source so you can biopsy it and plan definitive management.
Next up, nasopharyngeal carcinoma.
This cancer is heavily linked to distinct regional and viral risk factors. You need to tie nasopharyngeal carcinoma to Epstein-Barr virus reactivation, as well as specific risk factors like Asian ancestry, a diet rich in salted fish, smoking, and genetics. On the exam, always group the symptoms into 3 testable buckets. First is obstruction, which causes nasal congestion, epistaxis, and headaches. Second is mass effect, triggering cranial nerve palsies or obstructing the eustachian tube to cause otitis media. And third is regional spread, presenting as cervical lymphadenopathy. For diagnosis, you'll use an endoscope-guided biopsy, and treatment typically involves radiation and chemotherapy.
Let's move into the oral cavity with the oral leukoplakia workup.
We need to correctly identify and triage precancerous mucosal lesions. Oral leukoplakia presents as a painless, white mucosal patch that cannot be wiped off, and it's strongly driven by tobacco and alcohol use. Persistent or concerning lesions, especially those over 4 centimeters or with a non-homogeneous appearance, require a biopsy, immediate tobacco cessation, and close clinical monitoring. The crucial distinction here is telling this apart from oral hairy leukoplakia. Hairy leukoplakia shows up as multiple white corrugated lesions, specifically on the lateral borders of the tongue. It's induced by the Epstein-Barr virus, occurs almost exclusively in immunocompromised patients, and mandates immediate HIV testing.
Finally, mediastinal compartment masses.
Let's map out the thoracic cavity by categorizing mediastinal masses strictly by their anatomical compartments. Use spatial anchoring with this cross-sectional diagram to rapidly memorize the differential. The anterior compartment sits right behind the sternum. The middle compartment houses the heart, pericardium, trachea, and esophagus. This is where you suspect bronchogenic cysts, tracheal tumors, pericardial cysts, lymph nodes, lymphoma, and aortic arch aneurysms. The posterior compartment aligns with neural tissue and the vertebrae.
The anterior compartment is classically defined by the 4 T's. That's thymoma, thyroid neoplasms like ectopic or substernal goiters, teratomas and other germ cell tumors, and terrible lymphoma.
Keep in mind, a large thymic shadow is an entirely normal finding on a frontal chest X-ray in children under the age of 3. However, if it's missing in a young patient, that should immediately raise concern for severe immunodeficiencies like DiGeorge syndrome or severe combined immunodeficiency. We'll wrap up in the posterior mediastinum, where the dominance of neural tissue dictates that we primarily look for neurogenic tumors, like schwannomas and neurofibromas, along with meningoceles, spinal metastases, enteric cysts, and diaphragmatic hernias. And as a quick cleanup point, always suspect acute mediastinitis after cardiac surgery if a patient presents with a fever, chest pain, leukocytosis, and mediastinal widening on a chest X-ray. That presentation demands immediate drainage, surgical debridement, and prolonged antibiotics.